Okay, hi everyone. Today I'm going to be talking about a project entitled Longitudinal Structural Covariance Associated with Antidepressant Electroconvulsive Therapy Response. And I just briefly want to frame the motivation for some of this work. We know that depression is the primary cause of disability worldwide. Unfortunately, remission rates following standard first-line interventions like SSRIs and cognitive behavioral therapy remain rather low, around 25 to 50%, which leaves a lot of room for improvement. And part of the difficulty in treating depression seems to stem from its overall symptomatic heterogeneity. So for example, there are about 227 potential symptom combinations that can lead to the same DSM-based diagnosis of depression. And it's entirely plausible that there are a variety of differing underlying neural mechanisms underlying these symptom constellations. This is a problem that's compounded, especially in clinical trial and experimental settings where the severity of depression or its response to treatment is mostly assessed on the basis of some total score like the Hamilton Depression Rating Scale, which is a multi-item scale capturing a broad range of symptoms in depression. And so clearly summarizing the severity of depression on this basis can ignore some of the patient's idiosyncrasies. And so with that, the aims of this study were to identify latent pre-treatment symptom dimensions in a large cohort of ECT patients, and then later identify how changes in these symptom dimensions associate with changes in patterns of longitudinal structural connectivity over treatment. Just for anyone who may not be familiar with it, electroconvulsive therapy is the induction of a grand mal seizure by way of an electrical current delivered to the brain by scalp electrodes. This is typically reserved for more treatment-resistant patients or people who are imminently suicidal, but it does elicit a very high acute response rate of about 60%. But because it's not typically a first-line treatment, most ECT imaging studies are relatively underpowered. So to address these questions, we partnered with the Global ECT MRI Research Collaboration, GEMRIC, which is a collection of 15 imaging ECT studies from around the world and headed by Leif Oltedal out of Bergen. I'm working with a subset of this data, which is 111 ECT patients drawn from 4 of the participating GEMRIC sites. Of course, treatment protocols did vary across these sites, but generally speaking, they followed the outline below, where patients underwent both imaging and HDRS assessment within 24 hours before their first ECT session. On average, patients underwent 9 rounds of ECT over the course of 4 weeks. And within a week of completing the ECT series, they again underwent imaging and an HDRS assessment. And so we conducted an exploratory factor analysis of the 17 items of the Hamilton Depression Rating Scale at the baseline time point, and we observed that there was a 3-factor solution that best captured the variance within this data. And this roughly clustered these 17 items into dimensions of somatic disturbances, core mood and anhedonia, and insomnia. And so individual patient weightings onto these latent symptom dimensions are the outcomes for the models that I'll be discussing subsequently. And again, part of our goal here was to relate patterns of longitudinal structural covariance to changes along these symptom dimensions. So I just briefly want to outline how we went about this. We used FreeSurfer to segment subcortical volumetric regions and cortical thickness of these patients pre and post ECT MRIs. So this results in 48 estimates of cortical thickness and subcortical volume. And for each subject, we calculated the % change in each of these ROIs over treatment. And additionally, the pairwise ratio of these % changes between each pairing of these ROIs. And so this results in 111 48 by 48 ratio matrices, 1 per subject. We next thresholded each of these ratio matrices using 8 adjacent but non-overlapping windows over the distribution of these ratios between the values of 1 to 10. This process, in this framework, these windows that are closer to 1 capture patterns of similar structural changes between ROIs over treatment, while higher valued windows closer to 10 capture more divergent or dissimilar trajectories between ROIs. And so the result of thresholding these ratio matrices in this way is a set of 8 adjacency matrices per subject, which can then be represented as graphs as shown here below. In each of these graphs, a node corresponds to an ROI, and an edge between two nodes indicates that the ratio of change between these ROIs is within the window ratio that the underlying adjacency matrix was derived from. So to make this a bit more concrete, for example, if a patient's right hippocampus node in a graph emerging from the ratio window 2 to 3 has 5 edges, that would suggest that this patient's right hippocampus changed 2 to 3 times more than 5 other regions. And so we can take the set of all of these node degrees from across all subjects in windows and use them as predictors along with patient age, sex, site, and baseline severity to predict changes along each of these latent symptom dimensions. And here I use 10 repeated tenfold cross-validation with a process of nested feature selection to do this. This is the result of that cross-validation process. In the right, I'm showing the predicted versus actual changes along each of these latent symptom dimensions. And for comparison, the same for the HDRS total score. And what's immediately apparent here is that the correlation between the predicted and actual changes in these latent symptom dimensions is significantly higher than for the Hamilton total score. So this starts to suggest that modeling these more homogeneous outcomes could serve as better outcomes for models attempting to predict clinical outcomes following a variety of treatments, as well as for biomarker discovery. So next we might start to ask, what are the underlying patterns of structural connectivity that associate with each of these latent dimensions, and to what extent are they shared across these dimensions or perhaps unique? And so in this figure, I'm plotting the 5 networks that were most significantly associated with change along the somatic factor. There's obviously not time to detail each of these, but I can provide some highlights. So highlighted here in yellow, we observed that there was a network of moderate divergence between the left lateral occipital cortex and a variety of ipsilateral limbic regions, and in green, the right hippocampus and a variety of frontoparietal regions. And this is kind of interesting because a lot of these regions that are captured by these networks are involved in sensory integration and processing, and so they're very biologically plausible, and it's kind of cool to see them emerge here in this data-driven process. Another set of networks that we observed here captured more severe divergence between both the left anterior cingulate and the temporal lobe with respect to a variety of other sensory integration regions. Moving on to the anhedonia and core mood network, here we observed a network of moderate covariance between the right lateral OFC and a variety of ipsilateral frontotemporal regions, as well as contralateral hippocampus. And this is kind of interesting. Again, the temporal regions are commonly affected by depression, and the lateral OFC is commonly implicated in processes of emotional regulation, so perhaps fitting within the context of this mood dimension. Here we also noticed a network of moderate divergence between the right accumbens and a variety of ipsilateral limbic regions. Perhaps this is reflective of negativity bias and reward processing in patients with depression. And lastly, we have the insomnia networks. And this was well characterized by patterns of tight covariance between the right inferior temporal lobe and ipsilateral medial temporal structures, as well as contralateral hippocampus and pars opercularis. And finally, a network of moderate covariance between the left putamen and contralateral frontotemporal regions as well. And so to summarize, we conducted an exploratory factor analysis of the 17-item Hamilton Depression Rating Scale in a large cohort of depressed patients about to undergo ECT. And we identified that 3 latent symptom dimensions best characterized their symptomatology. We observed that changes along these latent symptom dimensions were better predicted than changes along the HDRS total score, which is what most related studies use as target outcomes. So this might start to suggest that these more homogeneous outcomes discovered by data-driven processes might better inform predictions of clinical outcome and biomarker discovery, as I mentioned before. We also observed that these symptom dimensions exhibited interesting, unique, but also overlapping patterns of associations with patterns of longitudinal structural covariance. And so this may begin to have implications for certain treatments As many suspect, perhaps targeted neuromodulation of specific networks, whether functional or structural, may affect specific symptom profiles differentially and start to inform more targeted and individually tailored treatment strategies, which is desperately needed in psychiatry. And so with that, I just want to thank all of you for your attention and say a special thanks to my mentor at UCLA, Catherine Nahr, and Leif Oltedal, who runs GEMRIC. Thank you.